Morning, Karina, or afternoon.
Morning.
How are you?
I'm good. How are you?
Doing okay, thanks. A little chilly where I'm at, but yeah, I think it's up to maybe 35. Started at 21, I think, this morning. Hey, Ashton, Kayla, and Andrea, how are you?
I'm good.
Hey,
How are you?
Ashton. Hi, Andrea.
Morning. How are you?
Good, good. Hey, Kayla.
I'm good. I'm sorry. I was trying to eat really quick.
No, no worries, no worries.
If I also have to disappear off of camera, this cold weather, well, it's not cold, it's cold for Florida, it's 60 degrees out, is literally killing me. And so I can't talk, and it sounds like I'm gargling gravel.
60 degrees in Florida. Where are you, Pensacola?
I'm in Atmore, Alabama. It's right on the Florida line.
Okay, but you're with the what camp?
I'm with,
Yeah,
yes, ma'am, I'm
Pensacola.
with Pensacola.
Yeah. So a whopping 60 degrees. Wow. I'd take
Although, in my
60.
defense, I do, so I work as like a health coach on the side, so I start work at 4 in the morning. And then it's normally about 40.
Okay. Well, later on in the term, I'll report my temperatures where I am.
Yes,
Um,
please.
they'll be pretty darn cold. I'm pretty far up in northwest Wisconsin, pretty close to the Canadian border.
Okay, that's where my dad drives. He drives the 18-wheeler and delivers chemical up there to New
Oh,
Jersey.
really?
Yes.
Okay.
He tells me about it all the time.
Yeah. It's been chilly up here. It's a little nice during the day, but it just gets freezing at night. So anyway, but I'll report. We're in the 30s today, so we're good. Yeah, but I'll be reporting when it's probably minus 20, minus 30. Although I teach in the RN program too. I teach. Obviously, this is the RN. I teach PN and RN, but our course lead, Annalena, Dr. Lundy, she lives up in North Dakota, and she just went through like a blizzard, an ice storm, winds like 50, 60 miles an hour.
That's crazy.
Yeah. Hi, Barbara, Nikki, how are you?
Hi.
Hi. If you guys would put your name and your campus in the chat, that'd be great.
I was gonna ask a quick question as well. Do you have any tips or tricks if we're because I'm learning the material and I'm reading the chapters, but it's not quite sticking for me. Like it doesn't make as much sense for me as like med surg and the other classes that I'm taking.
Mhm.
And so I just don't know what to do to fill the gap, if that makes sense.
Be a little bit more specific for me.
So on the test in particular, I was going over like what I was studying and everything, and I went over I think it was like a Alanis or Alani's review,
Mhm.
and that's the one that I watched, and it made sense to me. And when I watched the video, I understood everything she was saying, but in like practicality, taking that and answering the questions is what I was having issues on.
Okay. Why don't we set up a time to meet? Everybody processes the information differently. But why don't we set up a time to meet?
Yes, ma'am.
Okay, why don't we do that? And we'll go through your specific concerns, one-on-one.
Okay.
How's that sound?
Very good.
And then, well, let's see. Time do we have here? Okay. So for all of you that are just joining, if you put your name in your campus in the chat so I can do attendance that way, that'd be great. Okay, and I'll get started since I want to respect your time. Everybody, please, can everybody turn their cameras on, please? That's first. Hey, Dawn. And Lori Lee, can you turn your camera on, please? Thank you. Okay, so let's get started. Congratulations on exam one. The class as a whole did really, really well. You guys pleased? Overall, you did well. I reached out to students who scored below a 78 and offered to meet with them to review the exam, but I also wanted to extend that offer to everybody. Okay, so if anybody wants to meet to review their exam, even if you got in the 90s, and you want to know what questions you got wrong, please reach out. Okay, I'm happy to meet with anybody to go over the exam and go over the questions they missed. Okay. Anybody have any questions about the exam? Okay. Okay, so today we're going to cover the week 3 and week 4. We're going to mostly go from the book. So I've highlighted sections in the book that I think that are important for you to know to understand the concepts of each chapter and also meet the objectives. Okay, so a couple of things. I'm going to share my already recording. So let me make sure everybody's name is in the chat, please, with your campus. I'm going to share my screen here. Just want to go through the module for this week. Everybody able to, or whoever has any issues with access to your case study, your hospice case study? Everybody been able to get in and find it and know where it is? It's in your week 4 module link here. And you have to go through this link to get it done, okay? And as I said in the announcement, don't worry about providing me a screenshot of your grade because they populate right into the grade book anyway. Okay, so I don't need that from you. The other thing, let's see. The other thing in the announcement was, didn't I mention, let's see, I think I mentioned the infectious disease, right? Did I mention that in this week's announcement? Yeah. So your group, what I need for you guys to do is for your group to submit to me by next week, November 1st, submit to me the infectious disease you would like to do. Okay. And just let me know what you want to do. So I make sure we have a kind of spread out. Let's see. People do flu, Ebola, HIV, any kind of infectious disease from the CDC website. There's a link to the website in your module. Yes, Ashton.
And we're using the same group that we did for our last
Yep.
case study the entire term, right?
Yeah, and you have 2 projects. This is your second.
Okay.
This isn't due till, I know we're in week 4. It's due in week 7. So pick an infectious disease that you guys want to do. And just somebody send me an email that this group is going to do this infectious disease. Okay. And then if you look in week 7's module, when it's due, it has the guidelines. Let's just go flip there real quick. Let me get these last few people in. So let's go to our week 7 module. Okay, this is the project that also has a peer evaluation. Okay, so like your last project, your initial posting is due on Wednesday, and then you respond to your peers by Sunday. Okay, and same guidelines apply as far as everybody needs to submit. Okay. Each group will decide on infectious disease. And here's the website right here, National Foundation for Infectious Diseases, that you can pick one from. Okay. So just let me know what you want to do. And then here's your guidelines. It's the same kind of paper as last time. As far as having a cover sheet, APA format. Okay. So here's what you need to do: name, cause, symptoms, mode of transportation. You can read the different bullets of what needs to be in there. And then what I'd like to do, let's see, it'll probably be, it's due in week 7. So I'm going to spend the second hour of our week 8 lecture, and you guys are going to do like little mini presentations to the class. Okay. What you did, what you learned. And okay, so that's what we're going to do for week 8. All righty. Does anybody have any questions about that? This week all we have is our hospice case study. Next week we've got an NCLEX. Okay. All right. So does anybody have any questions? So by the end of the week, or no, maybe by the end of next week, or whenever you pick your infectious disease, just send it to me. Okay. Okay, so does anybody know, has anybody had a chance to review any of the readings from last week, which was 24, 25, and 26? Last week's content was rural and migrant health, several specific vulnerable populations, the poverty, homelessness, teen pregnancy, and mental illness. And then alcohol, pardon me?
I'm sorry, I didn't mean to interrupt.
Oh, that's okay. Go ahead.
I'm sure I speak for like pretty much everybody. I have not had a chance to go into the reading yet. Everything's been super busy with clinical and everything. But I try to go at least through the PowerPoints if you send them beforehand.
Yeah.
So I can get like a general knowledge of what we're going to be lecturing over.
That's great.
So, okay, I haven't had the chance to read though.
No, that's great. And that's why we send the PowerPoints out. I mean, if you can get to the reading before class, that's great. But if you can at least review the PowerPoints, because remember the PowerPoints, as I told you a couple of weeks ago, PowerPoint, it's this right here, your chapter outline. Your PowerPoint is a summary of this chapter outline. Okay, so
I have
you
a hard time using the electronic book too. I'd rather have it on paper, so I struggle with that as well.
do you have a paper copy of the book?
I do not.
Okay. Well, if you have you might want to consider getting one
Yeah.
if you have a hard time with online. Okay.
Yeah.
I try to make it a little bit more organized for you guys in the book. So if you review the PowerPoints before class, that's fantastic. And then we can go through, I can pull out different parts of the chapters in the book that I highlight. Okay. And so as we start going through the highlighted parts, those are the parts that I want to cover. I've already gone through all the chapters in the book, and I've highlighted what is the important information that you need to pull out to understand the concept of the chapter, which for this 24 is rural and migrant health. Okay, what do you need to understand so that we can understand the concept of rural and migrant health, and we can also be able to articulate and answer the objectives. All right, so as you see me scrolling through these chapters, I'm going to stop at my highlighted points. Okay, a lot of students like to follow along online with me and highlight what I've highlighted as well, or jot the page number, whatever. Okay, sound like a plan? And then I'm going to try and do this in an hour and 15 minutes, because I'd like to, or even an hour, I'd like to spend the last part of class. I want to do week 3 Kahoots and week 4 Kahoots. They were both really good. Has anybody done them? They were both really, really good. So I want to do that with you guys. Okay.
Quick question.
Sure, Ashton.
When you're saying that you're highlighting in your book and we like to follow along, is there a way that we can highlight our book from like the website that it's on?
I'm pretty sure. Yeah. I have students that highlight and follow along with me all the time. Yeah.
Do you know how to do that?
I don't from a student perspective. I don't, okay. But I know it's possible because lots of students do that.
Okay. Thank you.
Yeah, you're welcome.
Ashton, there's on the top right of the screen where the page is, there's a big A and a little a, and you can choose your colors there. And you just click and highlight, click and drag.
Great.
Thank you.
Thanks, Don. Okay, so when we think of rural health, migrant health, what do you guys think of? So let's start with rural. When you think of rural health, what comes to mind?
More on the outside of town, rural areas.
Mm-hmm.
Patients not able to get to appointments.
Pardon me?
Like patients not being able to make their appointments far out from healthcare, like elderly.
What else do we think about in rural settings? I currently live in a rural setting, or I'm up here in Wisconsin, in a very, very rural setting. Very less populated, right?
Think of low income areas.
Low income, lots of poverty. Okay.
Farmers,
agriculture. And the second part of this chapter is the migrant worker. What's a migrant worker and how do they relate to rural communities? Okay, let's learn. And remember, the outline, all these blues are hyperlinks. Okay, so if you want to go back and review a section, these are all hyperlinks, as well as the key terms. So if there are terms that you don't understand when we're reading through the chapter, please make note of that and go back and review that term. Okay, so one of the biggest issues in rural health is access. Okay, Access to a lot, access to healthcare, access to doctor's appointments, like Wendy said, access to transportation to get to appointments. Okay. Really, really, really big issue is access. Okay. So box 24.1 here on page 421 gives you some terms and definitions. Okay, so have a look at these. It talks about what is a rural community? Fewer than 20,000 residents or fewer than 99 people per square mile. Okay, and then it compares it to what a metropolitan area might be. What is suburban? Okay, so what is farm residency? These are the two I really would like you to know: farm residency and rural. Okay, the definitions of those. Okay. What are some population characteristics of the rural what are population characteristics and cultural considerations for the rural population? Okay. Demographics suggest that white people, white compromises 80% of the rural population compared to about 60% in the cities, in the urban population. Hispanics are about 9% and African Americans are about 8%. Okay, typically one of the issues in rural populations are they're underinsured or uninsured. What does that mean? They don't seek out health care. A lot of times in the rural population, rural population is not focused on preventative care. That's just a given. They're not focused on primary care, preventative care. It's not that they could care less, but they just don't have, whether it's the motivation, the finances, they're just not focused on their prevention level care, primary care. So what happens? We tend to see them in the urgent cares and the emergency rooms at a much more advanced stage of their condition, their disease. Does anybody live in a rural community or a family that lives in a rural community? So a lot of this, Ashton, this will hopefully ring a bell for you. It certainly does for me where I am. When I teach this chapter on rural and migrant health, it's exactly what it's like up here for me up in Northwest Wisconsin. Okay. I'd like for you to review these social determinants. Remember, we talked about social determinants, meaning what determines health. Okay, what determinant means what determines something. So these are 9 examples of social determinants, right, that are barriers for people trying to access healthcare, okay, in the rural community. Poverty rates, cultural and social norms, low literacy level is certainly a barrier in the rural community. Language barriers, affordable and reliable transportation is an issue. Unpredictable jobs, work hours. Typically, people who work in the rural communities it's probably likely they don't have health insurance, which means they don't have dental insurance, which means they don't have vision insurance. Okay, lower population we talked about. And then certainly a decreased resources, whether it's actual physical resources or whether it is physician resources, healthcare resources. It's really hard to recruit to work in the rural areas. Okay, lack of access to healthy foods or physical activity options. Okay, so that's a good list of 9 barriers that will help determine if 1 or 2 are in place. It may not be horrible, but if you have all these barriers in place, it is going to be a real struggle. Okay. And then I want to review this box, characteristics of rural life. Okay. I'd like for you to review these boxes. I do have this one in yellow because I want to point this out, okay? You can read through this, but lack of anonymity is a big problem in the rural community. Why do I say that? Why is it an issue?
Because
Okay,
everyone knows everyone in a small town and people talk.
Exactly.
Nobody
Exactly.
has anything better to do other than gossip. I live in a small town too.
Yep, yep. So what issues does that create? What happens?
It can cause issues whether it show favoritism to certain people in the community, or it can cause like negative impacts to people who are not so well liked in the community. Like it could interfere with jobs, medical care, anything like that for the biased person.
Right, right.
Someone also might be reluctant to even get health care because of someone knowing like a diagnosis that isn't favorable. Like, for example, if you're diagnosed with Tourette's in a small town, that could very well get around town very fast, then you know how that would go.
Absolutely. And you guys are definitely on the right track. That's perfect. Thank you. A lot of times it will prevent people from coming to seek healthcare. And in the rural communities, we have increases in violence, in domestic violence, in child abuse, in spousal abuse. And so we may not typically see a battered victim until they're in the emergency room, and it's obviously a serious situation. People in rural communities are much less likely to seek out care
They have
because
a fear of embarrassment.
yeah, and fear that everybody knows.
It's hard not to when they go to church with the doctor.
Exactly. Or there's a couple of stories in this book about the school nurse who works in the rural community, but she's also the labor and delivery nurse at the hospital. She's also the immunization nurse at the public health department. And so she knows everybody from the whole community in many different settings. Okay, so lack of anonymity, I just want to point that out, is a big problem because we're not kept abreast of what's going on, and sometimes we get involved in the situation when it's way too late. Okay, so a few other things. It's very cyclical or seasonal, especially with the migrants. Migrants is a seasonal job, so you've got people coming in and out. It's a much more spread out community where residents live far, far apart. Certainly it has the high risk occupations, farming, agriculture based jobs, right? With big farm equipment, risks for accidents. Okay, much more risk occupations as well. Okay. And then there's certainly a mistrust for newcomers. Okay. So as we talked about in general, people in rural areas have a much more poorer perception of their health. Okay. We talked about they are much less likely to have insurance or prescription drug covers. Right. They're much more likely to be involved in accidents. More than 50% of vehicle crash related fatalities occur in the rural area. Somebody already mentioned the traveling time. What if you have a high risk pregnancy? What if you have cancer and you need chemo and you have to travel great distances to the next big city? Well, one of the biggest barriers in the rural population is transportation. Okay. Women's health, women and children's infant health. Okay, it is a fact that the mortality rates are much higher in the rural population. Okay. The other issue is female victims of sexual assault are another very high risk group in rural areas. Children are very at risk in rural areas. Okay, rural areas are less likely to have a specific pediatrician. They may have a family health doctor. Do they specialize in pediatrics? Who knows? Right? So they're seeing often they're seeing a general family practitioner. Okay, think about the kids who work on farms, work on ranches. Think of what they're exposed to. Lots of hazards. And we'll talk about school nursing later on, but school nurses play a very important role in the rural America. Mental health. Mental health is also a huge issue in rural populations. Okay, think about all the difficulties they already have. Okay, they already have poverty is very high in the rural population. Unemployment is very high in the rural populations. Okay, when they have the cyclical jobs, that's very stressful. Okay, the incidence of domestic abuse, of substance abuse, of alcohol abuse, very high in the rural population. Okay. And then occupational environmental issues. We talked about this, about the number of accidents. It's a primary industry. This industry is very high for hazardous exposures to machinery, for accidents. Okay. Forestry. Here are the four predominantly high risk occupations are in forestry, mining, marine related fields, and agriculture. So remember that, would you? Right here, page 425. Okay, those are the four most common high risk occupations. Okay, accidents, cancers related to environmental exposure, allergies from respiratory conditions, pesticides. Okay, and this is important to know. The most common health issue for farm workers, there are 6 of them. Okay, but I want you to focus on this first one. The most common health issue for a farm worker is pesticide exposure. All the others are important: skin disorder, infectious diseases, musculoskeletal injuries, respiratory, pardon me, and hearing and vision, but pesticide is number 1. Okay, let's look at the levels of prevention. Remember, every chapter has this, and we need to be able to come up with a primary, secondary, tertiary for every chapter. Okay, so in this chapter, we're talking about rural migrant health. So what would be a primary prevention? Teach workers how to reduce their exposure, right? So we're trying to prevent something before it happens, right? Secondary, conduct screening such as urine testing for pesticide exposure. Well, we know this is already a high risk group. So this is a group we would screen to see if they were identified as having any kind of exposure. And then tertiary, we have to assume they have already been exposed, right? So tertiary would include treatment for symptoms of pesticide exposure. Okay, nausea, vomiting, skin irritation. Okay. Box 24.4 is another good box to review. It's our barriers to healthcare in rural areas. We've already talked about most of these. Transportation, having to drive long distances. The other thing is lack of telephone, lack of internet, broadband issues. That's an issue. Okay, unpredictable travel, weather or travel conditions, poverty, inability to pay for your healthcare insurance. Language barriers we've talked about. Okay, and then this makes a big difference here for nurses. Any provider. Providers' attitudes, insights, and knowledge about rural population are important. We need to make sure we check our own values and beliefs and our attitudes and our thoughts and feelings. You know, when these people are, the people who live in rural communities are already stressed. Okay, so they don't want to be judged. So if we provide demeaning attitudes, lack of knowledge about their population or their culture or their lifestyle, it can really cause problems in establishing relationships and trust with this population. Okay. Then the next section is about the migrant farm workers. We know migrant farm workers are seasonal, right? We know migrant farmers are critical to the agriculture industry in our country. Okay. We know that migrant farm workers, their lifestyle is often very unpredictable and very difficult. They have difficulties with housing. Okay. They may be not able to afford, they may be only able to afford living in a group house with lots of other families. All right. It may not even be available, maybe too expensive, maybe in poor condition. Right. Obviously, housing conditions vary among states and in counties, but a lot of times they're living in cabins, trailers, camps, tents. All right. And that creates very poor, unsanitary working conditions and makes these migrants much higher susceptible to problems. Right. What comes to mind is living in crowded home areas, housing areas, you know, much more at risk for something like TB. Right. We also know, like the rural population, behavioral health issues are big in the migrant population. Depression, anxiety, PTSD, just stress in general, right? Maybe related to isolation, maybe related to trauma, discrimination, economic hardship, legal status, poor living conditions. Okay, so they are riddled with mental health illnesses as well. Substance abuse in migrant communities is also an issue, as it is in the rural population. Okay. Children of migrant workers, significant risks, right? They're at risk for injuries, working with machinery, tractors, cars, ATVs, their weather exposure, heat, sun. Then their musculoskeletal risks, bending, twisting, okay, pesticide exposure, and then certainly lack of education. So rural migrant kids are very much at risk. Okay. Cultural considerations, we need to be culturally competent. Okay, what does that mean? We've talked about that before. We need to appreciate and understand the cultural backgrounds of the individuals. Okay. Majority of migrant farm workers are of Mexican descent. Okay, so the few things I would like for you to look at in this section are health, values, and beliefs. Take a look at that section on page 434. And then let's review the Healthy People 2020 box. Okay, again, like the levels of prevention box in every chapter, these goals and objectives are important for nurses who work with rural and migrant populations. So this is so they have 3 objectives specific to this population. Okay, so please be aware of those. I would suggest, and I suggest this every term, make little flashcards for your Healthy People 2030 boxes, because there are questions from certain chapters about what Healthy People 2030 objectives are. Here there are 3. Reduce unintentional injury deaths, reduce work-related injuries resulting from missed days at work, and reduce deaths from working-related injuries. Okay. And then I always suggest, this is I'm not going to go through this, but to read this, remember this section at the end of every chapter. This is a fantastic summary of what was covered in the chapter. Okay. Next, let's talk about some very specific homeless, we've already been talking about vulnerable populations. Let's identify 4. The client that's in poverty, homelessness, teen pregnancy, and mental illness. Again, your PowerPoint is a summary of this chapter outline. Okay, and it has 4 sections: poverty, homelessness, adolescent sexual behavior and pregnancy, and then mental illness. So, and these are all hyperlinks, can take you to each section. Okay, please be familiar with the objectives, because that's what I'm pulling out of the chapters. Okay. And you have your keywords here. Okay, understanding vulnerable groups. I want to skip to this box here. Okay, how do we check our own practice? How do we examine our beliefs, our values, our knowledge about these populations? Here's some questions to consider. When you're doing health screening at a homeless shelter, one of the clients asks you for money. Do you give it? Let's say you're driving down the street and you see a homeless encampment. What do you think? God, I'd like to get out and help them, or well, I don't know what you think. Right? When you make visits, a home visit, and you're in a very unclean, unkept home, and the client offers you food. Right? What do you, again, these are just questions to ponder. And there's no right answer, but they're questions for us to ponder. Okay. How do you, the last bullet is interesting. How do you effectively advocate for clients with seriously mentally ill diagnoses who you know need treatment, but can't afford to go into, can't afford the resources to get treatment? How do you feel about young teenage girls who are pregnant? Can you adequately care for them without being judgmental? Or, and the same goes for homelessness. Can you adequately care for them without being non-judgmental? Do you understand what they're going through? Are you willing to investigate what their beliefs are, their values are, their knowledge of their current situation is? These are the 4 most common vulnerable groups. And I'm sure you have every one of these groups in your own community right now where you live. How much do you know about them? These are pretty popular. These four vulnerable populations are pretty popular for your week 9 project. I get a lot of project PowerPoints on homelessness. I get a lot on teen pregnancy. So these are, you know, if you'd like to use one of these 4, remember this chapter. This chapter is an excellent resource for that project. How do we define poverty? Right? Well, we have federal poverty guidelines that are established federally, and they're adjusted every year based on whatever the financial targets are. Okay. So basically poverty, the kind of the formal way to describe poverty is it means that you have insufficient resources to meet your basic needs. Okay, what do these basic needs include? They include food, shelter, clothing, transportation, and healthcare. That's what's considered basic needs, basic living expenses. Okay, so you have insufficient resources to meet basic living needs. Okay, this is a good little list of what we know that the causes of poverty are multiple, right? Here are some common causes of poverty: decreased earnings, increased unemployment rates, changes in the labor force, increase in female-headed households. That's an interesting one. Inadequate programs, inadequate benefits, inadequate services, weak enforcement of child support statutes, okay? And the rest of them as well. Okay, we know that poverty is affected throughout the whole lifespan. Okay, we know that there are poor health outcomes from poverty, right? We know that those are much more consistent in the rural community. Okay. Poverty affects children significantly. I want you to review this box. Okay, well, how does it affect children? Well, starting at birth, increased higher rates of prematurity, low birth weight babies, birth defects, higher mortality rates, chronic diseases, nutritional deficits, higher risk for infections, higher risk for homelessness, decreased opportunities for education, income, and occupation down the road. Okay. Homelessness. How do we define homelessness? Well, we know that poverty can lead to homelessness, right? And they say that although people who have never been homeless cannot truly understand what it's to be homeless, what we can do as nurses, increase our knowledge and increase our sensitivity, right? Asking them about their own personal beliefs, their values, their knowledge. Okay, there's 3 types of homelessness is broken up into 3 different kinds of categories. You have transitional, episodic, chronic. You have chronic, transitional, episodic. And I've highlighted those 3 for you right here. I just need you to know what the names of them are. What are the 3 types of homelessness that are identified? Chronic, transitional, episodic. Okay. And you can read those. On a single night, on any given night, close to 600,000 people experience homelessness. Okay. And a lot of those, over, let's see, I think it's 33%, 34% are families. Okay. We know that mental illness is a huge issue with homelessness, right? 1 in 5 homeless persons have a severe mental illness. And they most likely have a issue with substance abuse as well. Right? So when you put severe mental illness and substance abuse, that typically creates that category of chronic homelessness. You have comorbidities. Okay. Another vulnerable population that's increasing is veterans with regards to being homeless. We do know that homelessness is definitely correlated with poor health outcomes, right? They typically suffer from multiple health issues in relation to the general population, right? Maybe due to weather exposures, disease, violence, unsanitary living conditions, stress, nutritional issues, addictions. Okay, they're at much higher risk for things like TB, HIV, AIDS. And then where do they seek healthcare? Are they focused on they're not really focused on primary care. When do we see them? When they get really sick, right? We see them, homeless people seek the great majority of their healthcare through emergency departments. Okay. What are our Healthy People 2030 goals related to poor, homeless, teen pregnancy, and mental illness? There's 3 of them. We're on page 447. Increase the proportion of homeless adults with mental health problems who get services. That's a great objective. Reduce the proportion of people living in poverty, great objective, and reduce pregnancies in adolescents. And remember that people are homeless at all different points of the lifespan. So imagine the different effects it has on, for example, pregnancy, a pregnant homeless person, kids, infants, kids, adolescents, high schoolers, older kids, elderly. Everybody has different needs. We need to be aware of what the different needs are for the different populations. I mean, you may have a family, a mother who's homeless with 4 kids, and the ages range from 2 to 19. All those kids have different needs and different issues, right? And that goes through a few of the categories right here. And then what do we know about teen pregnancies, right? We know that it has a significant effect on communities, right? Teens who are pregnant require additional resources, additional support, and those resources and support seem to be decreasing in communities, right? Many of the teenagers who become pregnant are also caught up in the cycle of poverty. Maybe they're dropped out of school. Maybe they don't have a lot of options. The book states that there are 4 social determinants that will affect the health of teen pregnancy rates. Okay, and those are income, education, social support, and the living environment. Those are the 4 main drivers of what determines teen pregnancy rates. And we just talked about them a minute ago. Poverty, dropping out of school, lack of social support networks, whether that's family or extended family, and where they live. Okay. Okay, special issues in caring for the pregnant teen. One of the issues one of the issues is violence. Okay, teens are much more likely to experience violence during their pregnancies than adult women, right? And then prenatal care is an issue. Okay, their lack of seeking prenatal care. All right, and we know that teens are generally don't have adequate prenatal care. Therefore, they are associated with increased risks to both mom and baby, which increases mortality and morbidity. Okay. The result, low birth weight infants, preterm deliveries, nutrition for both mom and baby, and then infant care, right? Many teens who have babies may not be feel competent about the care of their new baby. Okay. And we'll talk about the faith community-based nurse here in a little bit, but faith community-based nurses are very involved in new families, new babies, especially with the teens, right? Let's say you're going out into the community and doing visits with a teen mom who's just had a baby. What are the things you look for? Are they bonding? Is there eye contact? Can she meet the needs of the baby when the baby cries? Who's involved? Who's helping her, if anybody? And then the other important thing is schooling and educational needs. one of the things, if you're working with teen moms, one of the things that is fact is that if we can get them to stay in school during their pregnancy or get right back into school after their pregnancy, it gives them much more opportunity for a better outcome for both themselves and the baby. Okay, so they may be dropping out of high school while they're pregnant. But one of the biggest goals for this group is to get them back into school as soon as we can, or try and keep them in school. Okay. The last vulnerable population is mental illness. Okay, mental illness is a incredibly huge issue in our current environment. Okay, I think the pandemic made it a whole lot worse, especially for the younger, you know, the kids from college all the way down. But mental illness is something that we're dealing with across the whole lifespan. Okay, who are our at-risk populations? Okay, what I just need you to know is who are our populations at risk. So we know kids and adolescents are at risk for mental illness. Okay, we know that adults are obviously at risk for mental illness. Okay. And then adults with serious mental illness. Okay, those are our at-risk groups, but you need to be aware across the lifespan, kids with mental illnesses look a lot different than adults with mental illnesses, right? And then the elderly and mental illness. That's your fourth group. Okay. This, I always love this. I don't need you to know or memorize anything on here. I have this saved on a separate document, and I give out resources all the time. This is a great list of resources for helping people with mental illness or mental health problems. Okay, so it's on page 459. Great resource. Okay, let's go through our levels of prevention related to mental health. Okay, so this is a good list. It gives several bullets for each one. What's primary prevention with regards to mental health? We're trying to educate populations about mental illness, teach stress reduction techniques, support and provide prenatal education, support to caregivers. Okay, so we're trying to prevent things before they happen. Secondary, maybe we're screening people to detect mental health disorders, providing mental health interventions after stressful events. So they haven't quite been diagnosed with PTSD, but they have witnessed or been involved in a significant event. We know they're going to be at risk. And so how do we work with them to try and provide some interventions so that it doesn't progress to a severe mental illness, right? And tertiary, we're assuming they have some kind of mental illness, right? So activities, provide health promotion activities to people with serious and persistent mental health issues. Support groups with those who have mental health disabilities, and then advocate for rehab and recovery services. So those are all tertiary. And I love this. I've highlighted this whole thing. I just want to read it to you. This is good. Nurses have a critical role in the delivery of healthcare to poor, homeless, mentally ill, and other high-risk people. To be effective, nurses need a very strong physical and psychosocial assessment skills, current knowledge of resources, the ability to communicate respect, dignity, and value each person, right? We need to be able to work with our clients to promote, maintain, and restore health, right? We have to be prepared to look at the whole picture, right? The person may be the client, but they have a family and they live in a community. And all those factors must be considered. Okay. And then please take a look at your remember this. Okay. And then the last chapter for this content is alcohol, tobacco, and other drug problems in the community. Okay. Again, I've gone through the objectives, pulled out information below to help support the objectives. So let's go through that. We know that substance abuse is the leading national health problem. It causes more death, illnesses, and disabilities than any other health condition. Okay. The scope of the problem is huge. Okay, whether it's alcohol, tobacco, OD stands for other drugs, by the way, in this chapter. ATOD is alcohol, tobacco, and other drugs. Okay, so we know that ATOD, abuse and addiction, can cause numerous health problems. Okay, whether it's lack of knowledge about the drugs, using the drugs, trafficking the drugs, the scope of the problem is huge. Okay. You can, I've highlighted things in this chapter. You can kind of breeze through it as well. I'm not going to cover this chapter really in depth because what I want you to know is alcohol, the issues with alcohol, tobacco, and other drugs, the specifics of them. So alcohol, right? We know alcohol is the most widely used psychoactive drug in the whole world. Okay. Costs billions and billions of dollars in lost productivity, property damage, medical expenses, alcohol-related illnesses, accidents, violence, child abuse. Okay, tobacco. Okay, obviously the ingredient in tobacco is nicotine. Okay, your body develops a quick tolerance for nicotine. Your e-cigarettes. Okay, e-cigarettes are just as harmful. Right, so if you're working with a family and the goal is to have a smoke-free home, and the the parent says, "Oh, I smoke outside now." Okay, well that's better. Or I only smoke a pack a day instead of 3. Okay, well that's better. What if they say, "Don't worry, I switched to e-cigarettes"? Is that still a huge concern? And why? Well, e-cigarettes are just as dangerous as cigarettes, right? Caffeine is also in this chapter. Okay, it's rarely considered a drug, but it is a stimulant. Okay, marijuana, opioids, cocaine, amphetamines, methamphetamines. Okay, so what is the role with alcohol, tobacco, and other drug issues? What is the role of the nurse? Okay, harm reduction. That's an important word, harm reduction. Okay, that is a primary care approach to substance abuse. All right, harm reduction focuses on health promotion and disease prevention. Okay, so we're trying to promote healthy lifestyles. We're trying to help with resiliency. And then the other part is education. Okay, education about the drugs and guidelines for their use. We as nurses can be effective in teaching, promoting, facilitating people to choose healthier options rather than trying to rely on drugs. Okay, and this paragraph here talks about peer pressure. You can try and teach clients, whether they're kids or adults, to be assertive in their relationships with others and how to make better decisions. Looking carefully at each person. Right? But we do know that people turn to medications like these, stimulants, when they have chronic health issues, sleeping, muscle issues, lack of energy, stress, mood swings. Okay. So as nurses, we can help clients understand that medications may mask the problems rather than solve them. And there are levels of prevention are related to ATO-OD. Primary would be provide community education to teach healthy lifestyles, focused on how to resist getting involved in the use of alcohol, tobacco, or other drugs. Secondary, institute an early detection program in the schools, the workplace, other areas to see who's at risk, or who's at risk for substance abuse, or who may be using substances. And then tertiary, they already have an issue. So we're trying to, what we would do would be to develop programs to help or reduce or end substance abuse. Okay. And then you have your healthy people goals. Have a look at those. They're on page 476. Okay, please know these. There's 3 of them. Okay. And then I want you to jump down to remember this. Okay, so that's what I want you to know for this chapter. All righty. Any questions on those? Okay, I want to jump to government, law, policy activism. I'm going to really quickly go through this chapter. What I really want you to understand about this chapter is who are our resources, who makes our decisions for public health. Okay, are they international, federal, national, local? Okay. So federally, we have the Department of HHS, Human Health, Health and Human Services, that directs the care, not so much care, but it puts out all of their guidelines, recommendations to all the states. Okay. Okay, so what I'd like you to know is that what is the function of the government? Okay, so at a federal, state, local government, they carry 5 healthcare functions. Okay, they are financing, information, policy setting, and public protection. Okay. And these are carried from federal down to state, down to local. Okay, everybody has these functions. They just are at different levels. And it goes through each of them. I want you to know a little bit about the Shepherd-Towner Act. Okay, it's on page 62. Okay, this was an act that had nurses available. This is really the beginning of women's and children's programs. Okay, and what they specifically focused on, one of the things that they specifically focused on was vaccines. That's what I want you to remember about that. Okay, provided hospital services and facilities for women and children. Health services for women and children, well child checks, child development services, vaccine services. Okay. Yeah. Okay, the Healthy People 2030 box looks a little bit different in this chapter, okay, because it gives you a span of 30 years, actually. Okay, so it has, I highlighted these four because I just wanted to give you an example. Here's how goals and objectives have changed. Okay, so this is the same goal, but over 30 years. So way back in the 90s, when they created this, the simple goal was increase the years of healthy life for Americans, increase the number of years. Then 10 years later, they did it again, but now they want to increase the quality of the years. Okay, and then 10 years later, now we want to attain high quality, longer lives free of preventable diseases. So they keep adding more detail and more content to the same goal. Okay, and then recently they just put out with Healthy People 2030, attain healthy, thriving lives and well-being free of preventable diseases, disability, injury, and premature death. So this Healthy People 2030 box in this chapter is meant for you to look at how these goals have evolved over 30 years. Okay. There's one international organization we focus on with this class, and it's the World Health Organization, WHO. Okay. Their main goal is to attain the highest possible level of health for all persons. And that means internationally. That's a pretty generic goal, but it's worldwide. Okay. So that is the only international health organization that we introduce in this class. Okay. Here are four things that they do to support their mission of attaining the highest possible level of health for everybody. So please be aware of these. Okay, day-to-day information service and the occurrence of internationally important diseases. Look at the role the WHO has played with the pandemic. All right, they publish international list of causes of disease, injury, and death, monitoring adverse drug reactions, establishing world standards. So if you get a question about the WHO on your next exam, you're looking for words like what? International. Right? Federal, we have our Health and Human Services. Okay. We have our, the other federal is our CDC. All right, so we have our HHS, CDC. We also have our NIH. So I just need you to know the names of these. Okay. HHS, CDC, National Institute of Health, which does research, biomedical research. And then the AHRQ, which is the Agency for Healthcare Research and Quality. Okay, and then the Centers for Medicare and Medicaid. So if you're asked a question about services or agencies, you've got your international, which is WHO. Then you've got your 5, 1, 2, 3, I think there's 5, 4. You've got your 5 federal agencies. Okay. And then below that, you have your state health departments, your local health departments, right? So scope of practice, this is in this chapter, right? So we all have, depending on what area of nursing we work in, we have scopes of practice. I had a school nurse scope of practice. There's hospice scope of practice, health, critical care scope of practice. Okay, what is a scope of practice, right? It's defining what our practice is. Okay. We're subject to the laws of our licenses in each state. Okay, so we have to work within the scopes of our care, whether it's OB setting, whether it's PED setting, whether it's ICU setting. Okay. And then the only other thing I want to cover is professional negligence. Okay. So professional negligence is another word for malpractice. Okay, it's simply defined as an act or an omission to act that leads to an injury. In order to be able to recover damages, you have to prove all these four. And you do need to know these. Okay, you were responsible to provide care within your scope of practice, right? You're responsible to provide care like any other reasonable nurse would in the same circumstances. You failed to act reasonably in the circumstances, and there was an injury. All right, so all four of those have to be met. You had a duty to provide care, you failed in that duty, and an injury occurred. Okay. And then have a look at this. Remember this. Okay. So that's what I want you to take out of that chapter, that we have agencies that coordinate our public health from international to federal to state to local. And that we always are having to practice our profession within whatever scope you're working under. Okay. I want to cover, oops, no, I didn't want to do that. I didn't want to do that. Sorry. What do you guys know about faith community nursing? What's faith community nursing? Anybody know anybody that's a parish nurse, or what do you guys know about it?
They treat patients with their religion, like they incorporate their religion in their care.
It adds a spiritual dimension into care. Right, right. So a couple of things about faith community nursing. Okay, more of a holistic approach, more of a focus on disease prevention. It adds the spiritual part. Now, when we talk about faith-based nursing, that can be whatever you practice. Okay, that can be Baptist, evangel, what am I trying to say? Catholic, evangelical, Baptist. It can be in a mosque, it can be in a church, it can be in a whatever. So whatever your faith is, this is what this is directed to. However you practice, wherever you practice, this is directed at all faiths. Okay. Does anybody know the difference between spirituality and religiosity? That should have been in your PowerPoints. Okay, religiosity is focused on a specific religion. So whatever your specific religion is, you would be that's religiosity. It's a specific religion. When you're talking about spirituality, it's what is your big picture? What are your overall, how do you see spiritually the world? Does that make sense? Where religiosity, we're focusing on one religion. Okay. And then here's some nursing things, nursing tasks that a faith community nurse might be involved in. Okay, and they also operate from their wherever, their church, whoever the governing board is of their church or mosque or whatever. The faith community nurse works within those goals. Does that make sense? So if it's a small community and there's not a lot of resources, the faith community nurses tasks may be limited. Okay, but here's a list of things that they might do. I can tell you, a lot of listening, a lot of health education, a lot of incorporating the spirit, whatever the religion is, the spiritual part of that religion into the care.
I have a
Okay.
question.
Yeah.
Okay, so we have a local hospital here in Pensacola. Before it was bought out by a bigger company, it was Sacred Heart. It was a Catholic hospital. And if you were affiliated with them, like you couldn't do birth control, you had to go by the Catholic religion. Would that be considered a faith-based care, even if it was a whole hospital?
That's a good question. I'm referring to faith-based nurses in the community.
Okay.
There's lots of stories like that all over the country, and it's a really, really it's a very discussed topic right now. So that's a good question. As far as hospitals go, I mean, I worked in a hospital when I was in Colorado. I was a director of women's and children's services, and it was attached to a Catholic hospital. And there were certain procedures that were not performed or were not allowed to be performed, but that was back in the 80s. But yeah, it's just a very, very interesting topic right now. But as far as the community goes, let's say you're from a specific religion that doesn't support adoption. I don't know, adoption. That congregation would probably not have adoption counseling as part of the faith nurse's job. Does that make sense? It's directed on what the religion, what the congregation, what are the goals and the objectives of the congregation? What do they want for their faith-based parishioners? That's a good question, though. Really good question.
Okay, thank you.
Yeah, sure. And so here's your differences between religiosity and spirituality. That meets one of your objectives. It's on page 520, right? So your behaviors are associated with the specific religion, right? And here's the fancy way to describe spirituality: your attitudes and beliefs related to the transcendence, God, or the non-material forces of life and nature. Okay, so it's your big view of the world. Okay. Levels of prevention. Let's review that. Okay, so this is with regards to faith community. Okay, encourage activities and group interest and discourage extended inactivity. So I guess that means get people moving. Encourage healthy snacks. Initiate a walk for fun program. See, these are all preventative things. Host a community health fair. Okay, secondary, provide health assessments and counseling during home visits. Right, when making home visits, identify certain risks, safety, whatever. Do a behavioral risk survey. Maybe to identify poor health behaviors. Tertiary. Let's see, the first one here deals with overweight, obese people. Right, collaborate closely with the ministerial team about sessions that deal with overweight and teaching about maintaining healthy weight. Okay, and then the second one is working with people with chronic diseases. And the third is working with people with mental illnesses. So they already have established diagnosis conditions. All right, so part of the faith community nurse is the nurse emphasizing the whole person health promotion and disease prevention. Okay, with the spiritual piece added. Okay. We talked about the spiritual piece, the roots of faith-based nursing, having both knowledge and skill of nursing, use nursing sciences, use humanities, use theology. So incorporate prayer, whatever your definition of theology is in your religion. Okay. There are two models, here they are. There's two models of the faith community nurse that I want you to understand. One is called the institutional model, right here, and one is called the congregational model. I just need you to know a simple definition of each. Okay, and this is based on what the mission of the congregation is. Okay, so a congregational model is where the nurse works within the congregation. Okay, it's just her and the parishioners. Okay, they're not working with any outside forces. It's her and the parishioners. Okay, she's governed by the congregation. She's directed, she's evaluated by the congregation itself. Okay, if you are a faith-based nurse and you're working as part of in an institutional model, it means you're partnering with the community. You're partnered with a healthcare institution, whether it's a long-term care facility, a hospital. Okay, and so you are reaching out to help your parishioners get additional services, if that's the goal of the congregation. Does that make sense? It's institution to institution. So you may be partnering with ride shares, transportation, getting your members to doctor's appointments. You may be physical therapy, occupational therapy, home health. You're partnering with outside organizations to assist you in providing care for your congregation. Does that make sense? It's pretty simple. One is working directly with the congregation. The other one is institutional, working with other institutions, okay, to get their care done. Okay. And then there's your Healthy People 2030 goals related to older adults in faith communities. So have a look at that, please, page 529. Okay. And then certainly go through, remember this. If you don't have time to go through all these chapters, at least go through what we are covering. Start with this list right here. You remember this list. It's just a fabulous summary of the whole chapter. Okay, so does anybody have any questions about faith-based nursing? Brings a spiritual aspect to the kind of the whole person care, is limited as to what the goals and objectives of the congregation is, usually involves lots of health education, lots of new family visits, how do you care for your baby, okay, teaching. And then the last chapter I want to go over is the public health nurse, home health, hospice. So we're starting to look at specific roles of community nurses. Okay, we talked about this in week 1. What do you think a community nurse does? Okay, so we've looked at the faith-based nurse. Okay, now we have a public health nurse. Now we have a home health nurse. Now we have a palliative care hospice nurse. Next week, we're going to look at the occupational nurse. So these are all the different types of nursing that are performed in the community. Okay, and we lump these three together in this chapter. Okay, so once again, go through your objectives, please. Okay, so we know, I'm just going to read this to you, the public health, home health, hospice, palliative care, we are rapidly expanding our specialties under public health, under community-oriented and population-focused practice, right? And we follow our nursing process, right? When we're practicing, just like we would do in the hospital, we do this in the community. When practicing these particular specialties, public health, home health, hospice, right? We are providing comprehensive assessment, planning, intervention, evaluation. We are using the nursing process in the community as well. Okay. So who provides home health, hospice, palliative services, right? When I say palliative services, that's also hospice. Okay. Who provides this care? Okay, well, here's the team. Okay, nurses, social workers, PTOT, aides, home health aides, LPNs, chaplains, physicians. Okay. What are our primary levels of prevention? Let's do that. It comes up at the beginning of this chapter. Okay, so primary, the nurse administers seasonal and newer strains of the flu vaccine or provides case management intervention so clients obtain vaccines. So getting vaccines to prevent the flu. Secondary, right? That would be a home visit, right? We're going into the home, we're monitoring the home for safety, environmental issues, safety issues. So we're really doing a risk assessment. And then we may be going back and working collaboratively with other members of the team for interventions. Okay. And the example they give is monitoring for medication side effects. You know, if they're starting on a new medication, they might be at risk for some side effects. So we have screened them, they've started a new medication, we know they're at risk. So now a secondary prevention is monitoring for side effects. Okay, the tertiary involves a diabetic client. Right? Can they take care of themselves? Do they know what a healthy diabetic diet is? Right? Come up with a plan for prevention of infection, complications, self-care with regards to diabetic care. Okay. So we know that home health nursing as a definition is a specialty area of nursing practice, right? Where we're focused on health and well-being of a patient or a client, their family, and the caregivers within their home, right? Home health, we are doing more in home health in the last 10 years than we ever have. So much of what used to be done in the hospital is being done in the home setting. Clients want to be in their home for their care as much as possible. Okay, home health is a holistic approach. We're trying to empower the clients or families, the caregivers. We want them to achieve the highest levels of physical, psychological, functional, spiritual health. All right, this also includes end of life, right? We provide home health to ages all across the lifespan, including end of life. And that's where your hospice nurse comes in. Okay. And then I'd like for you to understand the difference between skilled nursing care and skilled nursing services with regards to Medicaid. Okay. So for example, they don't include non-skilled nursing care is like your ADLs, right? If you're going in, doing your ADLs, that is not Medicaid reimbursable. However, if you're providing skilled care or you've taught a family member to do skilled care, that is. Okay, so there's a difference. One of the big differences is like 3 big differences between Medicare, Medicaid reimbursement, and one of them is skilled versus non-skilled nursing services. Okay. And then this section goes through hospice and palliative care. Okay. Here's a description of hospice and palliative care. Okay. It is similar, but different. Okay. From the home health nurse. Okay. This is your team. Okay. This is your team and these are your functions. Okay. Or I'm sorry, the team is very similar to the home health nurse, but here's the different functions that they would perform versus a home health nurse. Okay. Holistic, evidence-based practice, emphasis on ethics, because now we're dealing with end-of-life care. Being able to communicate. What if you're working with a family of, what if you're taking care of an end-of-life client and you have family members that are in disagreement of what the plan of care is? Or you have family members, I mean, obviously one of the goals of a hospice nurse is to bring everybody in, right? Bring everybody to the bedside, everybody's involved. But if you have family members that don't want to be involved, how do you deal with that? Right? How do you coordinate the care for families that may be out of state? There's a lot of issues that go on in hospice nursing, right? What are your values, beliefs about end-of-life care? Right? Are you okay with symptom management, pain relief, and comfort? There's a lot of additional education and certifications that you need to have to be a hospice nurse. Okay, and there's again your team, which is pretty similar to the home health team. Okay, this includes pharmacists, which is kind of what end-of-life care is all about, is comfort care. Okay. I think that was it. And that talks about educational backgrounds, which we don't need to go over. And then, Healthy People 2030, here's their objectives for the year of 2030. Reduce cancer death rate, increase proportion of cancer survivors who are living 5 years or longer, and on. So you can read through those, but please be familiar with these. Okay. And where's our levels of prevention box? That was at the top. We already covered this. And then please go through your remember this. Okay. Excellent summary. Okay. That's our content. I want to just jump to, I want to jump to our week 4. How's everybody doing? First of all, everybody doing okay? Is this helpful information?
Yes.
Yeah, I mean, lots of different roles in the community. Let's go to the current. Hang on. Let's see. I'm going to put this in the chat, or I could just put it in.
I have to grab my computer charger real quick.
Yep. We could just do it like this if you want, and I can go through it and you guys can just kind of talk out what the answers are versus everybody getting set up. Let's just do that. Okay, so this is for the faith community, home health, and government agencies. Let's see what we got here. Okay. This is about the increased education. The green one. Okay, so the one thing, I know you have to have your med-surg experience. I know you have to have your master's degree, but the most important thing with regards to faith-based nursing is that you have your evidence of mature faith. That's the most important thing, because that's what faith-based nursing is. And you do not need to convert to Catholicism. In fact, the book does say that you can be working as a faith-based nurse in a religion that you may not practice, but as long as you have an understanding, evidence of mature faith, you can work in that. Does that make sense? Okay. What do you guys think?
Be blue.
Red. Nope, it's
Okay, why is that important? Why is that important? Remember, you're dealing with hospice. So why is that question important? Well, think about it.
To make her feel
Are they
more.
afraid they might die in their sleep?
Exactly. Exactly. And what is hospice care all about? End of life comfort, pain control, dying with dignity, dying with feeling cared for, feeling loved. And so if they say they're most concerned about being alone at night, that has to be that's part of hospice care, is that doesn't happen.
Quick
Make
question.
sense? Yep.
So would that be the correct answer, because it says in quotations most concerned, so that's what the client's most concerned about? Is that the
So-
key there?
Say that again, Ashton.
So I'm confused. I know that it's hospice, but the main goal of hospice is to like manage symptoms and everything, right? So the way I thought about the question was more about like the bowel and bladder problems, because that would lead to a lot of discomfort, a lot of skin irritation, would be pretty much painful. But if the client says most concerned about being something, then you'd go to their first concern.
This is all about end of life care. Right?
Okay.
And so whatever places them at the highest comfort level, we need to work with. If they don't want to be alone at night, that is something the hospice nurse needs to work out with the family or work out.
Okay.
Okay.
The yellow one.
Remember the role as a facilitator. Okay. You guys understand why that's correct and the other ones are not? Okay, they're working as a facilitator. Right, so they're working with the church. Okay.
Primary.
Everybody understand why that's primary? Or somebody articulate for me why that's primary.
Because it's before you even get the flu.
It's prevention.
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 Red.
Beliefs and traditions help with coping.
What do we think it is?
The red one. Yeah.
Yep. Yep. Belief with traditions.
Red.
Yeah, belief in traditions with help and coping. That's adding the spiritual aspect to this. Which of the following principles is central to the role of the parish nurse?
Willingness to serve anyone in need.
Which one?
The green.
I'm gonna say the blue one.
Remember, it's a spiritual, that's the whole crux of faith-based nursing is the spiritual dimension of care. Not that the other ones aren't important, but the spiritual dimension is the most important.
Blue.
Blue.
Everybody understand why the right answer is blue?
Blue.
It's end of life care.
Providing palliative care. Maintain comfort.
Everybody understand why it's that? We're talking end of life care.
Green.
Green.
That's okay for her to say. I prefer that she said Medicaid costs are such a large portion of our state's budget, but
I feel like
I
it's
mean-
inappropriate to say that.
It's very inappropriate to say that.
yeah, I don't really like this question.
And as a nurse, we don't really deal with the cost side of things either. We don't do the billing or how much it even costs to.
Well,
be
if
there.
you're in rural, if you work as a rural nurse, you do all that. You do. Yeah, I'm
Okay.
not real sure about that question. Yeah. I don't really like that question either. Which best describes what are the outcomes of the incentives and pressures for cost control? What's up and coming?
Green.
Telehealth, the green.
What, right? I mean, what are we doing? What have we been transitioning towards the last couple of years? What has the pandemic showed us? That we can get a lot of our healthcare done through telehealth services technology, right? We talked about this.
Blue.
Red.
Right? This is skilled versus non-skilled care.
Red.
Yep. All right, I'm gonna stop there. How many questions did we get through? If I were you, I would go through the rest of these, okay?
Red.
And then I would also go through, I was gonna do week 3 Kahoot with you as well. I would also go through your week 3 Kahoot. All right, so you've got 2 sets of Kahoots to go through. Do you want me to put these 2 links in your chat?
Can you put it in the announcements?
Yeah.
Put in announcements.
Yeah, I think that week 4 is already in there. I just put in there this week. I
Okay.
just don't know if I have week 3 in there. Have you guys seen a week 3 Kahoots?
I've not checked this
All right.
week. I've
I thought I put it in there as part of the announcement in week 3, but double check. There's 2 available to you, week 3 and week 4. Okay, and Professor Price, who does the Kahoots, she really spends a lot of time going through the questions, and I think she does a good job of it. I do. A couple of questions are, so I'll talk with her about that. I didn't like the question about telling patients that how much we spend. I don't like that. Okay, let's go to our attestation. Let's go to our week 4 attestation. Julie and Wendy, can you guys turn your camera on, please? Oop, did I lose Wendy? Hey, Julie, you're not driving, are you? You are? Okay.
Yes, I am.
Okay. Okay, what are the questions?
What are 2 parish-based modules for faith?
You're cutting out. I can't hear you. What is it?
What are the 2 parish-based modules?
Oh,
for-
yeah. Okay, so what are the 2? Remember we talked about them? What are they? Congregational.
The first question is, what are the 2 parish-based modules?
Okay, so we talked about the 2 of them, right? Congregational. What's the other one?
Was it the
Begins with an
religious-
I.
No, just kidding.
Go ahead, Ashton. No, go ahead.
Institutional.
Institutional. Thank you, Jean. And what are each of them? If somebody wants to talk out loud to let your teammates know, you can all answer it together. If somebody wants to put the answer in the chat for everybody, that'd be great. Annabelle, are you there? Oh, there you are.
This is
Okay.
5 modules.
I was looking at your picture on your wall. Okay, so we all know what each of those are, or does anybody need help? Okay, what's our second question?
Says,
Please
please list the 5
Please
practice
list
models
5
for the home
practice
health and hospice community nurse.
Oh, please list the 5 what?
The 5 practice models for the home health and hospice community nurse.
Okay, hang on. We didn't go through that, but I'm going to show you where it is. Let's see. There is a nice diagram. Where's that diagram? Right here. Okay. Read that question again, Ashton.
Says, please list the 5 practice models for the home health and hospice community nurse.
Okay. Okay, there's your 5 practice models right there.
official.
And then if you want to read more about each one of them, just go below this diagram and it tells you about each one. Okay. Actually, it's right here. It's right above it. Okay. So when you're done, hit submit. Everybody have those? If you need more time, it's on page 536. And please take a look at this little box above, box 30.1. These are your different models. Okay, your official, your voluntary, combo agencies, hospital-based, and proprietary. Okay. So we did cover a lot today. I appreciate your patience. We're all caught up. Again, go if you haven't opened the book yet, when you go back to the book, please just go to the parts of the chapters that support the objectives. Okay, please don't feel like you need to read, what did we do, six chapters from start to finish. That's not the intent. Okay, the intent is that you can articulate the objectives, which is what I tried to cover in the chapters today. And somebody let me know, I'm going to assume you have, I know you have Cahoots 4. I'm going to assume you have 3 unless I hear from somebody that you don't, but I would highly suggest that you review 3, week 3 and week 4. This is good practice. And then please let me know before we come to class next week, somebody take the initiative of sending me whatever infectious disease you guys want to do. Okay.
And that's just one person per group to email you,
Yeah,
right?
just one person. Okay. Yep, that'd be great. Anybody have any questions? Well, it's hump day. So tomorrow's Thursday and you're almost done with week 4. Do you guys have any exams this week?
We have peds at 3 o'clock.
Today?
Some of us. Yes, ma'am.
Oh, okay. Well, let's get going so you guys can catch a break.
Real quick, I looked in the announcements and I did not see the week 3 Kahoot.
Okay. All right.
This week 4.
Yep. Thank you.
You're welcome.
I'll send that out. Cool. All right. You guys have a good rest of the week and please reach out. Like I said at the very beginning, if you got anybody wants to review their exam, irregardless of what score you got, pardon me, please reach out. I'm happy to review your exam with you. Okay. 80s, 90s, whatever you got. If you want to find the few questions you got wrong. It sounds good, Savannah. I'll look forward to hearing from you. just let me know. Okay? All right.
Thank
Bye.
you.
Yeah, you're welcome. Bye, everybody. Bye.